My name is Namatama Sivera, a student of the University of South Wales, currently doing a diploma in diabetes. This is a postgraduate diploma. This video is in fulfillment of my module assignment. This is module 5, and the topic is diabetic retinopathy in pregnancy. My outline will basically be trying to focus on the scope of the current problem at hand with an illustration from a local hospital. And then from there, we'll go on to discuss the definition, risk factors, signs and symptoms, management, recommendations, and the conclusion. Please remember, the focus will be on diabetic retinopathy in pregnancy. So to just illustrate the problem, these are statistics from a local hospital that had 219 total births or deliveries in a month. Of these deliveries, 3 were non-type 2 diabetes patients that underwent cesarean section as a mode of delivery. The interesting thing is that the indication for these cesarean sections was everything else and not diabetic retinopathy. This is because none of these patients were screened in the past 2.5 years for retinopathy. Therefore, we truly need to increase awareness in both patients and health caregivers. We'll go on to define what diabetic retinopathy is. This is a complication seen in both diabetes type 1 and 2, characterized by the abnormal growth and leakage, including blockage of retinal blood vessels, leading to vision loss and blindness. Risk factors include poor glycemic control, hypertension, obesity, diabetic nephropathy, and of course pregnancy, which is the focus of our discussion today. Signs and symptoms of diabetic retinopathy can be seen and rather are equally used in its classification. So the image shows what is seen in diabetic retinopathy. In the first stage, we find that this is a normal retina, there are no changes. But as we progress in the staging, so from stage 1, we have diabetic retinopathy going through several non-proliferative stages, which can be mild, moderate to severe. And these ones are characterized by microaneurysms. Then we go on to the development of cortical spots, and then we can see venous bleeding as well as hemorrhage. The interesting part about the proliferative stage is that this is where we have neovascularization, or the formation of new vessels. Other people can go on to develop maculopathy. Diabetic retinopathy in pregnancy. Currently, the incidence in type 1 diabetics stands at 63%, and then the prevalence in type 2 diabetes is at 14%, and we have a prevalence from 34 to about 72% in type 1 diabetes. The pathogenesis in pregnancy. The pathogenesis is alluded to the physiological changes that come with pregnancy. We have 40% increase in cardiac output, all this in a background of impaired autoregulatory mechanisms, which is a consequence of diabetes, results in increased blood flow, which worsens diabetic retinopathy. Placental growth hormone and increased insulin growth factor cause neovascularization. Increased pro-inflammatory factors cause endothelial damage. All these are responsible for the progression seen in diabetic retinopathy in pregnancy. In management, the focus and the reason I decided to present on diabetic retinopathy in pregnancy is that we have a short window, or rather intervention is most beneficial in the pre-pregnancy state. because at this point, before someone gets pregnant, they need to undergo counseling on the dangers that are associated with development and progression of diabetic retinopathy. Emphasis needs to be put on the preferred mode of delivery, which is cesarean section in this case. Before someone gets pregnant, there has to be optimization of glycemic control. Most importantly, a dilated eye exam needs to be done and the retinopathy staged. This is to optimize the treatment of retinopathy in this pre-pregnancy step using either laser surgery or anti-VEGF. Contraception is also advised. So really, after one conceives, there's not much that can be done away from optimization of glycemic control, as well as in proliferative stages. If it's staged as proliferative, then laser treatment is what's advised. This is because there are certain challenges that are seen in pregnancy. These challenges include the fact that surgery is avoided due to increased retinal bleeding. Anti-VEGF is not advised as it can cause spontaneous abortions and preeclampsia. This is because VEGF is needed for vascular development in both placenta and the fetus, hence abortion. The treatment of choice in pregnancy with proliferative diabetic retinopathy is laser. Recommendations as from the ADA are that vaginal birth is usually associated with increased chances of vitreous hemorrhage in those with untreated retinopathy. Epidural anesthesia should be given with assisted second stage to avoid pushing. Cesarean delivery is definitely the preferred mode of delivery. To sum it all up, the initial illustration showed diabetic patients whose seizures were done due to big babies and not retinopathy, and no screening was done. The aim of this presentation is basically to change the narrative of this story. It's clear that beneficial intervention has to be done before one gets pregnant, hence the need for increased pre-pregnancy awareness and screening for retinopathy. Thank you.